Ladies and gentlemen, we are now entering the fourth scientific session of 14th Annual Convention of Ahmadiyya Medical Association, Pakistan, which I hope would be very interesting for all of you because it's concerned not only with the surgery, but also with the dermatology, pediatrics, and ophthalmology. Before we start our program, I would like to invite a few distinguished guests to be the chairpersons for this session and request them to kindly come and take their seats. First of all, Dr. Mirza Muhammad Daud Sahib. Dr. Mirza Muhammad Daud Sahib is FCPS in pathology and served in Pakistan Army as consultant pathologist. He is currently working as Professor of Pathology at Rahman Medical Institute, Peshawar, and is also supervisor of postgraduate students. Then we have Professor Dr. Salahuddin Ayubi, FCPS. Dr. Sahib is head of ENT department at Medina Teaching Hospital, Faisalabad, and is also working as Professor of ENT at University Medical and Dental College, Faisalabad. Dr. Salahuddin Ayubi has also worked as ENT consultant in Fazl Umar Hospital for many years. Our next guest is Dr. Abdul Bari Sahib. Dr. Abdul Bari Sahib is son of Colonel Dr. Muhammad Abdul Khalik Sahib, former administrator of Fazl Umar Hospital, Rabwah. Dr. Sahib is an epidemiologist working in Islamabad. He also worked in West Africa for many years under Nusrat Jahan scheme. Currently, he is also serving as Amir Jamaat Ahmadiyya Islamabad, as well as President of Islamabad chapter of Ahmadiyya Medical Association. Dear doctors, the field of medicine is changing very rapidly. And if we want to keep ourselves up to date, we have to participate actively in continuous medical education process. We are all here for this purpose. This session will include presentations by 4 worthy speakers, followed by a short question-answer session. Now, we start the proceedings with the permission of the presiding chairperson. Time limitation rules would be the same as in the previous scientific sessions. Our first speaker today is Dr. Atif Mansoor Ahmed, MCPS, FCPS, FRCS. Dr. Atif Mansoor Sahib is a consultant ophthalmologist and head of Department of Ophthalmology at Sheikh Zayed Medical Complex and Postgraduate Medical Institute, Lahore. He is also supervisor for MCPS, FCPS, DOMS, and MS. He is also serving as General Secretary of Lahore chapter of Ahmadiyya Medical Association. I invite Dr. Atif Mansoor for his presentation about pink eye, predator or partner. Dr. Atif Mansoor Sahib.
Thank you. Jazakallah. Bismillahirrahmanirrahim. I want to thank AMA Pakistan for giving this opportunity to talk and share this information regarding a very common eye problem, which we noticed a few months back. There was a sort of epidemic which almost covered all the areas in Punjab and particularly the central Punjab. To start with, we need to know that every red eye is not a pink eye infection. There are many other causes which contribute to the presentation of red eyes, starting from the conditions related to eyelids, then conjunctiva, different types of conjunctivitis, even subconjunctival hemorrhage, episcleritis, scleritis, Then corneal conditions may also cause red eye, and similarly, the inflammation of uveal tract and acute congestive glaucoma. These are all causes of red eye, which we do consider while differentiating this type of condition. So what is the pink eye infection, which is projected so much in the electronic media? Thanks for the spreading the information regarding its mode of spread and prevention. So it is actually the viral conjunctivitis, and particularly with some specific type of virus and its specific serotypes. As the title of my presentation was predator or partner, so most commonly this type of conjunctivitis is caused by adenovirus, and there are certain strains which are present round the year, and they cause pharyngoconjunctival fever and different other types of presentations which occur sporadically. But particularly there are certain serotypes which are associated with the commonly named Ashobe Chasham or acute follicular conjunctivitis, and that is the pink eye infection actually, which spreads very rapidly because it is a very contagious type of inflammation. So transmission is by direct inoculation of nosocomial infection, droplet infection, by the upper respiratory tract infection, and as well as by the contact of the tear secretions, and these are transmitted by hand-to-eye contacts mostly. And as we all go out, move around the workplaces, in the markets, in our educational institutes, even sometimes traveling, because these viruses, they persist on dry surfaces for a very long period of time. So you can contact these or contract these infections from your community. So for this reason, we need to know various variants which can affect the eye in different ways. One is pharyngoconjunctival fever, which is a triad of clinical features like pharyngitis, conjunctivitis, and fever, and also associated with upper respiratory tract infection. Then epidemic, which we will talk in detail. Then acute hemorrhagic conjunctivitis. Some viral infections can cause profuse bleeding in subconjunctival area. Then we can have chronic type of viral conjunctivitis or relapsing adenoviral conjunctivitis, and there are other viruses which can also confound the picture. So in all these conditions, usually one eye is involved that is acquired from the common household, from the other family members, or from the community. And the symptoms have a period in which the infection spreads and it causes more and more discomforting symptoms to the patients, and also the other eye is involved in few days' time. And similarly, the common family members which are living in a common household, they are also infected after some days. Usually the family history reveals this condition that her younger brother or sister or elder, they might had that problem, and some days later that patient acquired that infection. So it is more severe, it is more contagious, and it is a health problem which should be notified in a community. Mostly it is associated with a specific type of follicular conjunctivitis, but sometimes the cornea is also involved, and that happens in second or third week of infection. Most of the cases are self-limiting, but the week or 2 weeks time in which the infection go on a rise and then decline, they are associated with severe form of discomforting symptoms. So keratitis usually second or third week, and it is more or less immune-based reaction, and this type of keratitis persists for many months or sometimes many years. So this picture is showing a distinctive type of viral keratitis, which is molluscum contagiosum, that is the lesion on the eyelid on the right side, while there is follicular reaction on the left side. We see in the palpebral conjunctiva, the part of conjunctiva which is lining inside of the eyelid. So the patient can have periorbital edema. They can also have pink eye. So you can see there is periorbital edema, there is swelling around the eye, as well as there is chemosis of the conjunctiva. And whenever we evert the eyelid or we retract the eyelid, there is more marked congestion in the conjunctiva, which is in the fornix or the junction between eyeball and eyelid. The congestion is more marked there. And you also see follicular reaction, which are actually mononuclear infiltration and surrounding reaction, just like a raised elevated lesions in the lower fornix. So there is also preauricular lymphadenopathy that is tender, painful, and many times the eye problem precedes or follow the upper respiratory tract infection. So here we can see the magnified view of these follicular reactions. We normally examine these patients in slit lamp by microscope, and with the magnified view we are easily able to find this peculiar feature which is present in viral conjunctivitis and very few other conditions. We can also see the formation of membranes, inflammatory membranes or pseudomembranes on the tarsal conjunctiva. And these membranes can sometimes, when they retract, they cause subconjunctival hemorrhages or profuse bleeding from the eyes sometimes in more severe forms. Here you can see a more magnified view of those exudative membranes on the conjunctiva, and when these membranes resolve, they tend to have residual scarring over the eyelid, which can ultimately lead to many eyelid deformities sometimes. Keratitis, I said earlier, is more common in second or third week of infection, and that might comes in the form of small punctate type of epithelial keratitis, followed by very small. This is a punctate epithelial keratitis which is stained with the fluorescent dye. Normally this dye is yellow or orange colored dye, and we see and photographed this lesion with the blue filter, cobalt filter light, and the areas which are affected in the epithelium, they are stained green because blue and yellow makes green. Later on, these punctate erosions, they settle, the epithelium heals up, but there are subepithelial infiltrates. These are just like shiny stars in the sky, and whenever these are present within the visual axis, they cause severe form of photophobia, in the discomfort in the light, and also glare around the light, especially the nighttime driving is very difficult. And these are the lesions which sometimes persist for many months, or sometimes in immune compromised patients, sometimes for years. So this is the type which can compromise the vision, and this is the type when conjunctiva, in addition to cornea, is involved, the patient can have glare as well as. So investigations are not generally needed. The mode of infection, the mode of transmission, the presence of disease in the community is sufficient enough evidence for having this problem, and the clinical examination is sufficient to diagnose this condition. But whenever we need, we can have these tests available with us for confirmation of diagnosis. Management generally needs the measures which we do practice in COVID. That was also another type of infection, viral infection. So we need to have good hand hygiene, use of sanitizers, washing of hands, so that whenever we are going out for a work or an education purpose or for a job perspective, we come back and or we reach our workplace, we should wash our hands, so that from the community, if we are acquiring this infection, this has to be transmitted from our hands to our eyes. So before touching, or avoid touching the eyes as well. In a common household, normally the towels, the soaps, as well as other fomites which are shared amongst the family members, if the patient or one family member is affected, they should be separated, and after resolution of infection, they should be properly sent to the laundry and cleaned up. Spontaneous resolution, that occurs usually in immune competent host in about a week or 2 weeks time, and all the array of treatment or management is basically symptomatic relief to the patients. So washing with the cold water, having cold compresses over the eyes, they reduce the eyelid edema, conjunctival chemosis, and then we do give decongestants as well as antihistamines to make the eye comfortable. Similarly, those follicular reactions, whenever we close and blink our eyes, they rub against the eyeball and they cause severe foreign body reaction. So whenever we are having this sensation, so lubricants, ocular lubricants or tear supplements, they are very helpful and we use them frequently. All these viral infections, normally the steroids should be avoided because they can prolong the infections. But whenever we are having involvement of cornea, that is an immune-based reaction. So in that case, we need to use mild steroids for a certain period of time so that the surrounding haze in the cornea that quickly recovers and that immune-based process is halted. So in that case, we add mild steroids like fluoromethalone or loteprednisolone. We should avoid strong steroids in all these viral infections. So whenever we are having those membrane formation on the conjunctiva, we normally give the lubricants initially so that they are loosened up and we can remove them gently in OR room. Sometimes they are so tightly adherent to the subconjunctival space that they profusely bleed. So we need to have this thing done in operation theater room rather than outpatient department. So there are other infections which confound this, but they are the infections which are having slightly indolent course and they continue to present different types of lesions on the eyelids as well. But all these infections should be considered in a differential diagnosis. Only these hygiene measures and cutting off the spread to the adjacent persons who are present in the family as well as on the workplace, this is the ultimate prevention of the spread of this infection. So I hope so, because our audience consists of many medical students as well as allied health sciences persons. So I tried to spread this information for all those audiences. Thank you very much. Jazakallah.
Very informative presentation by Dr. Atif Mansoor Sahab for almost all of us. Thank you very much, Dr. Sahab. Next presentation of this session is by Dr. Mubashir Mumtaz Sahab. Dr. Mubashir Mumtaz is the son of Lieutenant Mumtaz Anwar Shaheed of 1971 war in PNS Khyber. Dr. Mumtaz is a renowned consultant cardiothoracic surgeon, board certified by the American Board of Surgery and the American Board of Thoracic Surgery. He is working as the Chief of Cardiothoracic Surgery and Surgical Director of the Structural Heart Program in Central Pennsylvania. At the same time, he regularly visits Tahir Heart Institute and not only carries numerous surgeries, but also works as Deputy Administrator here. He also serves as General Secretary of Ahmadiyya Medical Association USA, as well as President of Harrisburg Jamaat. In 2017, Dr. Mumtaz received the Physician of the Year Award by Central Pennsylvania Parent Magazine. Contemporary treatments of aortic stenosis is the topic on which he is going to speak today. Dr. Mubashir Mumtaz, please.
Jazakumullah, Bismillah ar-Rahman ar-Rahim, Assalamu alaikum wa rahmatullahi wa barakatuh. I've just prepared a few slides regarding modern treatment of valvular heart disease specific to aortic stenosis. These are my disclosures. Aortic stenosis, as you well know, is narrowing of the aortic valve secondary to calcification. In the United States, that's mostly because of older age. It's called senile aortic stenosis. However, in Pakistan, the most common cause is rheumatic heart disease because of untreated or recurrent streptococcal throat infection. This is what an echocardiogram of a normal aortic valve looks like. You can hardly see the leaflets. This is the same ultrasound that we use in our GYN and OB practices. We use it on the heart. And In aortic stenosis, you can see the whitish area which is thickened, calcification, and you can see that there's only minimal opening of the aortic valve. In the operating room, after going on heart-lung machine and stopping the heart, we actually open the aorta to look at the aortic valve, as you can see here. And all this, this lumpy, bumpy stuff is calcification. So we cut the calcium out, and we can replace the valve with either a tissue valve, which could be a bovine valve, a porcine valve, or a mechanical valve, which is usually a metallic valve, usually carbon-coated. Mechanical valves last longer, however, require blood thinner throughout the life. Tissue valves last approximately 10 to 15 years. If you are more than 70 years of age, it may last up to 20 years. They're the most popular valves in the United States because people do not like to take blood thinners. And once the aortic prosthesis degenerates, that means the patient develops recurrent aortic stenosis or AR of the tissue valve. One can get a transcatheter valve inside the valve called TAVR, and I'll briefly talk about TAVR as well. In the past, we used to do open heart surgery through median sternotomy. These days, our practice is mostly a less invasive approach, minimally invasive approach, going through the intercostal area, which we call intercostal surgical aortic valve replacement. Generally, when surgeons started to do a less invasive procedure, they were cutting the breastbone in half or doing right anterior thoracotomy. In central Pennsylvania, we said we were going to go more laterally, and without cutting the ribs or cartilage or a major muscle like pectoralis major or minor muscle, we will do the valve replacement and repair. And over the years, we've been able to do not just single valve repairs and replacements, but also multiple valve repairs and replacements on routine basis. This is the incision we make. We make it into a more curvilinear incision because once the skin stretches, even though the incision measures 1 inch, you can see once we put a self-retaining retractor with a curvilinear incision, the incision becomes 2 to 2.5 inch incision. And then we essentially go to the rib space and get to the heart. We can replace the aortic valve through that route. We can also go and repair and replace the mitral valve through that route. And you can see as mitral valve is on the left side of the heart, it's in the back of the heart, the left atrium, and it's very easy access to the mitral valve. And aortic valve is just above the mitral valve in this area. So it really helps out. The patients get discharged much earlier. Blood transfusion rate is much better than open sternotomy. This is just an example of mitral valve repair. This is a mitral valve. It looks like a parachute cut in half, and you can see the posterior leaflet is overriding the anterior leaflet. This is because of degenerative valve disease in the United States. In Pakistan, it's because of rheumatic fever, so it's very hard to do these repairs in the tissue that is rheumatic, and the failure rate is also very high. So this is a Doppler on the echo. You can see all this green, yellow jet going backwards. That's abnormal jet of severe mitral regurgitation. In the operating room, we test the valve by putting saline into LV, and we can see this posterior area is prolapsing. This is called P2 prolapse, and we will repair this valve by cutting this leaflet out and putting the valve together, and then placing a ring in place. And this helps in reducing the recurrence of this mitral regurgitation. And then post-operatively, we'll see that that back leaflet that was coming up is no longer coming up, nice coaptation, and there's no jet going backwards. Aortic stenosis these days, apart from the minimally invasive surgery, the one important thing that happened within the last 2 decades is transcatheter aortic valve replacement, where we take a big stent and mount the valve inside it. In this case, porcine pericardium, in this case, bovine pericardium. We squish it down into a long catheter, and we then place it transfemorally into the aortic valve. So the wire goes all the way from the femoral artery into the LV, and then the sheath gets pulled backwards, and the valve inside, this is a self-expanding valve. It's called evolute core valve. It starts expanding on its own while the heart is beating. And this technology, initially when it came out in 2002, the first implant was done. Since then, has basically taken over surgeries for aortic valve replacement. So At one point, we were doing several hundred surgeries a year for aortic stenosis. At this point, we only do maybe 50 or 60 a year. In some ways, the surgeons also called it disruptive technology because within 16 years, we were able to produce data showing that this treatment was non-inferior to the gold standard at the time, which was surgical aortic valve replacement. And this is the timeline. Dr. Cribrier came up with this technique 2002, and since then we got all trials done in very high-risk patients, then moderate-risk patients, then intermediate-risk patients, and then low-risk patients. How did we identify their risks? We identified them based on Society of Thoracic Surgeons risk score, basically multiple factors taken into account, their age, how active they were, whether they had diabetes or not, kidney failure, lung issues. They all went into development of that score, and based on that, we identified a group of patients. We then, half of the patients received transcatheter valve, the other half received surgical valve, and then we subsequently compared those results. So currently in the United States, this valve is approved for all risk groups, which means low risk group. However, we're trying to not do it in younger patients because we do not know the long-term durability of this valve at this time. This is what happened in our hospital, that in 2016, we went from doing over 200 aortic valve replacements to slowly coming down, and like I said, currently we do 50 or 60 isolated aortic valve replacement. Obviously, the incidence of our surgical procedures of complex valve disease, where we have double valves, triple valves, have also gone up because we are identifying more patients, because more patients are getting echoes with multiple valve disease and complex valve disease. Who's the winner in this process? Yes, surgical volume went down, but these are the people who won. This is a 105-year-old lady that we actually ended up doing a TAVR on. So elderly patients, this was great. That means that prior to this, we were doing heart operation on these patients, and now they all get TAVR. They are in the hospital for one night, and they go home the next day. Surgery-wise, even though our single aortic valve volume went down, our overall volume went up significantly from valvular heart disease because we were doing more echocardiograms, and this was a new technology. Cardiologists in general were more enthusiastic. Our echo department increased like 2 or 3 folds. Initially, we used to have 2 echo techs. Now we have like 10 or 12 echo techs because everybody needs surveillance. There are new patients who are coming in. So a lot of times cardiologists were observing these patients in their offices prior to this technology. Subsequently, because it was much less invasive, much less traumatic for patients, we started seeing patients earlier in their disease process. All these indications got approved. There are many different technologies that came into place, just like all these satellites up there, but some of these satellites fall down. So there's several TAVR companies that also failed on the way, and currently we have 3 TAVRs that are FDA approved in the United States. One answer we still do not have is the durability. This is what happens to a surgical aortic valve. After a few years, when we take it out, it either gets calcified or fibrosed. So we need better tissue technology and better, or an alternate to tissue technology that will last longer. So this is one of those valves that are newer. This tissue technology is newer, even though it's bovine pericardium. The frame you can see is expandable, so it's more amenable for a valve-in-valve procedure with the TAVR later on. There's also technology where we can take out the calcium. So this is one such technology. It's called picardia, where rather than doing a balloon valvuloplasty, we can open up the aortic valve mechanically. There are also technologies having medicated aortic balloons, which may reduce the rate of calcification of aortic stenosis. So maybe if somebody has moderate aortic stenosis, you do a valvuloplasty with a drug-coated balloon, it might reduce the rate of calcification till it gets to severe. So we might be able to delay severe aortic stenosis in those patients. These are an example of polymeric valves. They are made out of silicone and polyurethane mixture, different kind of valve. This is one of the valves. The company is called Foldex. It's called Tria valve. I'm on the data safety monitoring board for this small company. They've put in several patients in humans, and they're monitoring their data. The main issue is thromboembolism, clot formation on these valves. Even though they're not mechanical valves, we still do not have a good answer as to how to completely prevent thromboembolism. So even though this is a polymeric tissue, it opens and closes like a native aortic valve, we may still need warfarin or anticoagulation in these patients, and this is still in trials. One thing that, due to encouragement of Dr. Nuri Saab, we learned very early on at Tahir Heart, because there was financial implications of valve replacement in Tahir Heart. A surgeon by the name of Dr. Ozaki was performing patient's own native pericardial valve formation and placement into the heart. It's called Ozaki procedure. And we visited him and learned the procedure from him, and subsequently were able to perform few procedures at Tahir Heart and over 60 procedures in USA. We take the patient's own pericardium and cut these leaflets out, place where the markers where the sutures should go in, and then we reconstruct the valve using that tissue into this kind of tri-leaflet valve that basically opens and closes. Normally this is like 3 months post or 4 months post, and you can see there's no AI. Our early experience did show that there was 10 to 11% failure rate. We also did the procedure in highly unselected group, very young patients as well. So now we're more selective, aortic annulus that is more symmetric. We try not to do it in bicuspid valves, so we're hoping our failure rate will improve. These are two of our very early patients, Kevin and Rose. They're both over 6 years, and we're monitoring their valves with every year echograms. There's been improvement not only in valve replacement, but also in other areas. There's been studies going on to look at the genetics of calcium deposition on aortic valve. People are looking at different medications that can prevent calcification specifically on aortic valve, which include medications which we use for hypercholesterolemia like Lipitor as well. And the hope is subsequently we can actually minimize the progression of aortic stenosis, or hopefully down the road even reverse that calcification with medications as well. And some of those medications might belong to biphosphonate medication, denosumab, these other medications. And then obviously, like I said, people are working on the genetic side of this as well. So in summary, aortic valve stenosis and the treatment of aortic stenosis and other valvular disease is evolving. We're trying to do it more and more less invasive, either transcatheter or minimally invasive through surgery. And also there are progress in terms of medical management of these therapies. We need better tissue treatments, so the valves are much more durable, or tissue alternatives that may last longer in these patients as well. Thank you so much for your time.
Very interesting and informative presentation about the latest advancements for treating aortic stenosis. Jazakallah, Dr. Mubashir Mumtaz Sahib. The third presentation of this session is by Professor Dr. Zahida Rani Sahiba. She is Professor of Rheumatology at Amiruddin Medical College and Lahore General Hospital. Her husband, Dr. Rafad, is also Professor of Medicine at Services Institute of Medical Sciences and Services Hospital, Lahore. Dr. Zahida is also the editor of the Journal of Pakistan Association of Dermatologists for the last 5 years. 60 research papers to her credit. Her topic today is child abuse and sexually transmitted diseases in pediatric population. Dr. Zahida Rani Sahiba, please.
Bismillahirrahmanirrahim. Assalamu alaikum. Thank you very much for inviting me here today. The topic which I'm going to present today is very important in a lot of ways, and it impacts all of us. What is child abuse? We'll talk about it first. And surprisingly, it is any act or failure to act by a parent or a caregiver that results in actual or potential wrongful harm to a child. And it can occur in a child's home or in organizations, school or communities the child interact with. اب یہ چیز میں تھوڑا سا ایکسپلین کرنا چاہوں گی کہ جب میں نے اس موضوع کے اوپر ریسرچ شروع کی تو مجھے یہ لگا کہ جیسے ہم مشرق میں ہمارے کرائٹیریا اور ہوتے ہیں اور مغرب میں بچوں کی حفاظت کے حوالے سے کرائٹیریا اور ہوتے ہیں، لیکن جتنا زیادہ میں نے اس کو پڑھا تو مجھے یہ اندازہ ہوا کہ ہم لوگ کچھ چیزیں اگنور کر رہے ہیں جو بچے کی ہیلتھ کے لیے بہت زیادہ ضروری ہوتی ہیں، اور پھر وہ آہستہ آہستہ جیسے میں آپ کو ایکسپلین کرتی جاتی ہوں کہ وہ کیا چیز ہے جو ہم یہاں غلط کر رہے ہیں. کیونکہ اپنی اس ریسرچ کے دوران مجھے یہ احساس ہوا کہ شاید ہم اپنے سارے بچوں کا ہی ابیوز کر رہے ہیں ایز پیرنٹس اور ایز کیئر گیورس. تو چائلڈ ابیوز کتنی طرح کا ہو سکتا ہے؟ چائلڈ ابیوز نیگلیکٹ ہو سکتی ہے، فزیکل ابیوز، سائیکولوجیکل ابیوز اور سیکشول ابیوز. یہ 4 چیزیں ہیں جو ہم کریں تو بچوں کی ہم زندگی برباد کر دیتے ہیں. نگلیکٹ کیا ہے؟ نگلیکٹ ہے انایڈیکویٹ ہیلتھ کیئر، کہ بچے کو کوئی بیماری ہے جس میں اس کو ڈاکٹر کی ضرورت ہے اور ہم اس کو وہ نہیں پرووائڈ کر رہے. بچے کی ایجوکیشن ہم ایڈیکویٹ نہیں پرووائڈ کر رہے. اس کو جو بچہ کام کر رہا ہے ہم اس کو سپروائز ہی نہیں کر رہے کہ وہ کیا کر رہا ہے، کوئی اپنے آپ کو کسی غلط راستے کی طرف تو نہیں لے کے جا رہا. یہ نگلیکٹ بھی چائلڈ ابیوز میں آتی ہے. اور ہم انوائرمنٹ میں جو ہیزرڈز ہیں اس سے بچا رہے ہیں کہ نہیں، کیا ہمارے گھر سیف ہیں ہمارے بچوں کے لیے، اور ان کی بیسک نیڈز جو خوراک کی ان کی بیسک ریکوائرمنٹ ہے کہ بیلنس ڈائٹ ہونی چاہیے، ان کا شیلٹر ٹھیک گھر میں ان کو صحیح محفوظ ہونا چاہیے، ان کے کپڑے ٹھیک ہونے چاہیے، ایجوکیشن، میڈیکل کیئر، کلین لیونگ انوائرمنٹ، کیا وہ ہم اپنے بچے کو دے رہے ہیں؟ اور اگر ہم ان میں سے کوئی چیز بھی نہیں دے رہے تو ہم چائلڈ ابیوز کے گناہ گار ہیں. اور یہ بچوں کے لیے سب سے کامن ٹائپ کا یہ ابیوز ہے جو اس کا کوئی بھی کیئر گیور کر سکتا ہے اس کی کیئر کے دوران. پھر آتا ہے فزیکل ابیوز. فزیکل ابیوز بھی ہمیں شاید مشرق میں ہونے کی وجہ سے ہمارے ذہن میں یہ فکس ہے کہ فزیکلی ہم بچوں کو تربیت کے لیے کچھ مار سکتے ہیں، لیکن اگر ہم اس کو اتنا انجر کر رہے ہیں فزیکلی اور اس طرح کے ایک ماحول میں رکھ رہے ہیں جہاں وہ اپنی جان کے لیے ڈر رہا ہے، ٹھیک ہے، اور اس فزیکل ابیوز میں بیٹنگ بھی آتی ہے، آپ بچے کو پکڑ کے جھنجھوڑتے بھی ہیں، وہ بھی فزیکل ابیوز میں آتا ہے، یا بائٹ کیا یا برن کیا. یہ چیزیں شاید ہم یہاں مشرق میں اپنی سگی اولاد کے ساتھ نہیں کرتے، لیکن مغرب میں وہاں پہ اپنی سگی اولاد کے ساتھ بھی یہ ہوتا ہے کہ شیکنگ، برننگ یا بائٹنگ ہو رہی ہے. پھر چھوٹے بیبیز کا فریکچر کر دیا، اتنا مارا کہ فریکچر کر دیا. اور پھر جو ہم اپنے ملازمین کے ساتھ، جو بچے ملازم ہم نے گھر میں رکھے ہوئے تو ان کے ساتھ جو سلوک کرتے ہیں فزیکل ابیوز میں وہ آتا ہے. میں ڈرمیٹولوجسٹ ہوں، تو جو اسکن کے اوپر جو بھی انجریز ہوتی ہیں یا جو بھی لیجنز ہوتے ہیں وہ مجھے ایک یونیک موقع ملتا ہے دیکھنے کا اور آئیڈینٹیفائی کرنے کا. پھر یہ فرق کرنا کہ یہ جو چیز لے کے مریض آپ کے پاس آیا ہے کیا یہ کسی ایکسیڈنٹ کا نتیجہ ہے یا کسی نے جان بوجھ کے بچے کو نقصان پہنچایا ہے، یہ ایک ٹیوننگ ہمیں اپنے آپ کی کرنے کی ضرورت ہوتی ہے. اور پھر یہ ڈیزیزز ہیں یا یہ انجریز ہیں، اور وہ کیسے آپ مختلف ہسٹری لیں گے پیشنٹ سے بھی، جہاں آپ کو شک پڑے گا کہ یہ ابیوز انوالو ہے تو اس میں آپ بچے سے الگ بھی پوچھیں گے اور پیرنٹ سے الگ بھی پوچھیں گے تاکہ سیکریسی بھی رہے اور بچے کا کانفیڈنس بھی بلڈ ہو. اب یہ جیسے نشان ہیں، یہ بیٹنگ کے نشان ہیں، بچے کے بروز بنا ہوا ہے، تو یہ بھی آئیڈینٹیفیکیشن ہونی چاہیے کہ آپ چوٹ کو کیسے پہچانیں گے کہ بچہ کھیلتے کھیلتے گرا ہے تو اس کو چوٹ لگی ہے یا کسی نے اس کو مارا ہے تو چوٹ لگی ہے. یہ بیلٹ کے مارنے کے نشان ہیں. बच्चे की कमर पे, तो ये भी आइडेंटिफाई ही फिजिकली देख के ही आप आइडेंटिफाई करते हैं। और फिर ब्रूज की एजिंग से आपको पता लगता है कि अगर एक बच्चे को लेके आ रहे हैं उसके पेरेंट्स कि जी ये गिरा है और उसको चोट लगी है, और आपको नजर आ रहा है कि 4 निशान हैं जिनकी एजेस फर्क हैं, कोई 4 दिन पुराना है, कोई 3 दिन पुराना है, कोई 7 दिन पुराना है, तो इससे भी आपके लिए डायग्नोज करना आसान हो जाता है। ये सिगरेट का बर्न है कि बच्चे को सिगरेट लगा के जलाया गया। फिर साइकोलॉजिकल अब्यूज क्या होता है? साइकोलॉजिकल अब्यूज जो है वर्बल अब्यूज है, ह्यूमिलिएशन है। आप बच्चे की बेइज्जती कर रहे हैं लोगों के सामने, उसका मजाक उड़ा रहे हैं लोगों के सामने, उसको डरा रहे हैं, जिसकी वजह से वो उस टाइम पे तो शायद वो सबमिसिव हो जाए और आपकी बात सुन ले, लेकिन ओवर द इयर्स उसकी एक पर्सनैलिटी में एक डिफेक्ट पैदा हो जाएगा, वो अपने लिए कुछ कर नहीं सकेगा। और अगर आप बच्चे के साथ नाराज हो जाते हैं और उसको इग्नोर कर देते हैं और आप कहते हैं कि तुम तो किसी काबिल ही नहीं हो, तुम तो दुनिया में कुछ कर ही नहीं सकते, तो ये एक तरह का साइकोलॉजिकल अब्यूज है जो काफी कॉमन है हमारे बच्चों के साथ होते हैं। और फिर वेरी वेरी सेंसिटिव टॉपिक सेक्सुअल अब्यूज का, कि व्हाट इज चाइल्ड सेक्सुअल अब्यूज, क्या है सेक्सुअल अब्यूज, जिसमें एक एडल्ट या ओल्डर बच्चा छोटे बच्चे को सेक्सुअल स्टिमुलेशन के लिए इस्तेमाल करता है। और उसमें ये हो सकता है कि एक्चुअली एक्ट किया जाए बच्चे के साथ, या सिंपली उसको एक्सपोज किया जाए अपनी ग्रेटिफिकेशन के लिए, एक छोटे बच्चे को एक्सपोज किया जाए किसी भी सेक्सुअल एक्टिविटी से। और इसमें शामिल होता है इनडिसेंट एक्सपोजर, यानी एडल्ट जो है वो अपने आप को एक्सपोज करे बच्चे के सामने, या बच्चे को एक्सपोज करे अपने सामने बगैर हाथ लगाए, दैट इज ऑल्सो चाइल्ड सेक्सुअल अब्यूज। और टच करना तो जाहिर है कि इनअप्रोप्रिएट टच जो है वो उसमें आ जाता है, सेक्सुअल अब्यूज में आ जाता है। और या पोर्नोग्राफी, ये भी सेक्सुअल अब्यूज की एक फॉर्म है। तो ये हमारे यहाँ कितना कॉमन है, वेस्ट के तो किस्से हम सुनते रहते हैं। पहले मैं आपको इंडिया का बता देती हूँ कि इंडिया में जब एक सर्वे किया गया तो 76% लोगों ने कहा कि हमारा अब्यूज हुआ है एज चिल्ड्रन। ये इतना बड़ा नंबर है। और उनमें से 40% ने कहा कि ये हमारे फैमिली के मेंबर ने हमारा अब्यूज किया। और ये बहुत दर्दनाक स्टोरी है। इंडिया से हम बहुत डिफरेंट नहीं हैं। और पाकिस्तान में सरकारी तौर पे तो कोई डाटा अवेलेबल ही नहीं है सेक्सुअल अब्यूज का। और जो एक प्राइवेट एनजीओ ने ये एक स्टडी हुई थी, ये डिपार्टमेंट ऑफ मेडिकल एजुकेशन सीपीएसपी ने ये स्टडी की थी, और उन्होंने ये बताया कि 15 to 25% चिल्ड्रन जो हैं वो पाकिस्तान में सेक्सुअली अब्यूज होते हैं। और एक कराची में एक स्टडी हुई जिसमें उन्होंने स्कूल के बच्चों से पूछा, तो उनमें से 88% बच्चों ने कहा कि हमारा फिजिकल अब्यूज होता है, मारा जाता है उनको। ठीक है, 17% बच्चे रावलपिंडी में उन्होंने कहा कि सेक्सुअल अब्यूज होता है, जिनमें से 5 लड़कों में से 1 और 7 लड़कियों में से 1। और जितने ये बच्चे जिनका ये इंटरव्यू लिया गया वो 13 साल से छोटी उम्र के बच्चे थे। और इनमें 80% में जो एब्यूजर होता है वो जानने वाला होता है। यानी ये जो हमारे माशरे में एक रिवायत सी नजर आती है कि ये जी कज़न है, ये अंकल हैं, ये चाचा है, ये मामा है, तो कोई बात नहीं है, बच्चे को वो उठा के ले जाते हैं और घुमाने के लिए। वो हम अपने बच्चे को इग्नोर कर रहे हैं। ये हमारी तरफ से भी एक अब्यूज है बच्चे के लिए, क्योंकि बच्चे को हम ऐसे हाथों में दे देते हैं जो सेफ हाथ नहीं है। और पाकिस्तान में 20,000 से लेकर 40,000 तक बच्चे प्रोस्टिट्यूशन में इन्वॉल्व हैं। जो एक एनजीओ ने, ये साहिल के नाम से है, इन्होंने पिछले साल जब सर्वे किया तो इनको ये पता लगा कि एवरी डे हमारी एवरेज है 2 घंटे में एक बच्चे का अब्यूज। और ये वो केसेस हैं जो रिपोर्ट होते हैं, और पता नहीं कितने केसेस हैं जो रिपोर्ट नहीं होते हमारे यहाँ पे। 2227 केसेस बच्चे जो पहले 6 महीने में ईयर 2023 में हुए थे। इन बच्चों में जो अब्यूज, ये जनरल अब्यूज की बात है ना, इसमें सेक्सुअल अब्यूज केसेस हैं, इसमें किडनैपिंग के केसेस हैं, मिसिंग चिल्ड्रन के हैं, और छोटी एज में जो शादियां होती हैं उनके केसेस हैं, और कुछ केसेस जो हैं वो पोर्नोग्राफी के, और एक केस ऐसा जिसमें घर का क्लोज फैमिली मेंबर जो है वो अब्यूज में इन्वॉल्व है। अब इससे क्या फर्क पड़ता है चाइल्ड अब्यूज से? हम अपने बच्चों को मार देते हैं थप्पड़, उसको कह देते हैं तुम जिंदगी में कभी कुछ नहीं कर सकोगे, तुम फेलियर हो, कोई काम तुमसे ठीक नहीं होता। इसका नतीजा क्या निकलता है? उसका ये नतीजा निकलता है कि बच्चे का बिहेवियर चेंज हो जाता है, उसकी थिंकिंग चेंज हो जाती है, वो अपने आप को प्रूव करने के लिए रिस्की एटीट्यूड जो है वो अडॉप्ट कर लेता है, और फिर क्या होगा, उसमें सेक्सुअल अब्यूज के चांसेस भी बढ़ जाएंगे। जब वो अपना बिहेवियर चेंज करेगा, ज्यादा लोगों से मिलेगा, और सेक्सुअल एक्टिविटी रिस्कियर पार्टनर्स के साथ वो इंक्रीज कर देगा, और इसी वजह से सेक्सुअल डिजीजेस के चांसेस भी बढ़ जाएंगे ऐसे बच्चों में। अब सेक्सुअली ट्रांसमिटेड डिजीज के बारे में कुछ बता देती हूँ आपको। ये हम लोग एज अ डर्मेटोलॉजिस्ट एक यूनिक पोजीशन में होते हैं कि सेक्सुअली ट्रांसमिटेड डिजीजेस ज्यादातर हम देखते हैं। तो इसमें ये देखा गया है कि अगर बच्चों में सेक्सुअली ट्रांसमिटेड डिजीजेस हमें नजर आ रही हैं तो उनमें से तकरीबन 74% बच्चों को सेक्सुअल अब्यूज की वजह से वो डिजीजेस हुई हैं। कुछ तो मदर से ट्रांसमिट होती हैं, बच्चों में जाती हैं, लेकिन ज्यादातर जो है वो सेक्सुअल अब्यूज की वजह से। और क्या क्या डिजीजेस ट्रांसफर हो सकती हैं सेक्सुअल कांटेक्ट की वजह से? गोनोरिया, क्लेमिडियल, सिफिलिस, herpes, warts, molluscum contagiosum, trichomoniasis, HIV, hepatitis B and C और bacterial vaginosis, ये सब डिजीजेस जो हैं वो सेक्सुअली ट्रांसमिटेड होती हैं। थोड़ा थोड़ा इन डिजीजेस के बारे में कि गोनोरिया क्या है। गोनोरिया ग्राम नेगेटिव डिप्लोकोकस की वजह से इन्फेक्शन होती है, और यूरेथ्रा में होगी, सर्विक्स में होगी, कंजक्टाइवा में और वेजाइना में हो सकती है इन्फेक्शन। और सिम्प्टोमेटिक वल्वोवेजिनाइटिस होता है गर्ल्स में, और मेल्स में यूरेथ्राइटिस होगा ये। और कल्चर करते हैं डायग्नोज करने के लिए, और एंटीबायोटिक के साथ इसको ट्रीट किया जा सकता है। फिर क्लेमिडियल इन्फेक्शन जो है, क्लेमिडिया ट्रैकोमेटस की वजह से होगी। आमतौर पे मदर से बच्चे को ट्रांसफर होती है, लेकिन सेक्सुअली ट्रांसमिटेड भी हो सकती है। और यूरेथ्राइटिस वेजिनाइटिस होगा, और मेल्स में भी इसी तरह एपिडिडमाइटिस और यूरेथ्राइटिस हो सकता है। क्लेमाइडिया की ट्रीटमेंट एजिथ्रोमाइसिन दी जा सकती है, एरिथ्रोमाइसिन दी जा सकती है। फिर सिफिलिस है। सिफिलिस माँ से बच्चे को ट्रांसफर होता है बर्थ कैनाल से, प्रेगनेंसी में हो सकता है, लेकिन सेक्सुअली ट्रांसमिटेड डिजीजेस भी हैं। और ये उसकी कुटेनियस मैनिफेस्टेशंस जो हैं वो चूँकि सेकेंडरी प्राइमरी में तो एक शैंकर बनेगा, सिर्फ सिंगल जो एरिया ऑफ कांटेक्ट पे बनता है, और यूजुअली वो अल्सर एसिम्प्टोमेटिक होता है, तो प्राइमरी वाला तो नहीं डायग्नोज होता। लेकिन सेकेंडरी सिफिलिस में जहाँ पूरी बॉडी के ऊपर एक रैश बनता है कॉपरी रेड कलर का, वो फिर डर्मेटोलॉजिस्ट के पास आते हैं और डायग्नोज होते हैं, और फिर इन्वेस्टिगेशंस फर्दर होती हैं। ये हमारे यहाँ सिफिलिस के बहुत पेशेंट्स हम देखते हैं। जैसे अब मैं लाहौर में भी काम कर चुकी हूँ, सियालकोट में भी काम कर चुकी हूँ, तो दोनों जगह मैंने देखा है सिफिलिस के ज़्यादा डर्मेटोलॉजिस्ट के पास केसेस आते हैं। और सिफिलिस के जो केसेस होंगे, मेल्स जो हैं वो आमतौर पे मदरसे के स्टूडेंट्स होते हैं, जो शायद अपने टीचर्स के हाथों अब्यूज़ होते हैं वहाँ पे। और इस तरह कि हमारे पास कोई चेक एंड बैलेंस का सिस्टम नहीं है कि देखा जाए कि वहाँ पे क्या बिहेवियर है, और वी एंड अप विद हैविंग चिल्ड्रन डेवलपिंग दीज सेक्सुअली ट्रांसमिटेड डिजीजेस, जो सारी ज़िंदगी के लिए एक तोहमत उनके ऊपर लगती है। फिर जेनिटल हर्पीस के पेशेंट्स हैं, जिसमें जेनिटेलिया पे पेनफुल वेजिकुलर इरप्शन होती है। फिर वॉट्स हैं, ये भी एनोजेनिटल वॉट, ये भी बहुत बच्चे आते हैं। ज़्यादातर बच्चे वही होते हैं जो मदरसों के स्टूडेंट्स होते हैं, जो प्रोबेबली अपने वही उस्तादों के हाथों अब्यूज़ होते हैं और वॉट्स डेवलप कर लेते हैं। फिर मोलस्कम कंटेजियोजम है, ये भी जैसे अभी डॉक्टर साहब ने भी दिखाया था आई में, इसी तरह के पर्ली वाइट पेप्यूल्स होते हैं जो पेरिएनल एरिया में, जेनिटल एरिया में अगर किसी भी बच्चे में हो रहे हैं, क्योंकि वैसे तो ट्रांसमिशन ये नॉन सेक्सुअल भी होती है, लेकिन अगर एनल जेनिटल एरिया में है तो फिर ये सेक्सुअली ट्रांसमिटेड, इसके बारे में। HIV है, बस अब एंड होने लगा। HIV का और हेपेटाइटिस B C का हमारे यहाँ कॉन्टीन्यूसली केसेस आ रहे हैं, जो हमें मीडिया के ज़रिए पता लगता है कि ये बच्चों का अब्यूज़ किया जा रहा है। बच्चों को बचाने के लिए कुछ वेबसाइट्स हैं, यूनिसेफ ने भी की हैं, जो आपको बताती हैं कि किस तरीके से बिहेवियर बच्चों को अपने सिखाना है कि क्या टच सही है और क्या टच गलत है। लेकिन एट द एंड ऑफ द डे वी हैव फेल्ड आवर चिल्ड्रन। थैंक यू वेरी मच।
Thank you so much for such an eye-opener presentation about a very important topic, rather very sensitive issue of our society. Jazakallah, Dr. Zahida Rani Sahiba. Now, the last presentation of this session is by Professor Dr. M.A. Nasir Malik Sahib. Dr. Sahib is the son of General Abdul Ali Malik Sahib. He graduated from King Edward Medical College, Lahore in 1975. He is a fellow of Royal Colleges of Surgeons of Glasgow and Ireland. He has been working as professor and head of surgery at POF Hospital, Wakent. Furthermore, he is also serving as president of Rawalpindi chapter of Ahmadiyya Medical Association. He is going to illuminate us about experience of thyroid cancer in a tertiary care hospital. Dr. M.A. Nasir Malik Sahib.
Jazakallah. Bismillahirrahmanirrahim. It's always a pleasure to come here and to give a talk on this topic, any topic. And I'm grateful to the organizers for this. So as you know, we'll be seeing cases about thyroid cancer. This is in two parts. First, our experience at POF Hospital, Wakent, and then a brief overview. So it was a 4-year study conducted at POF Hospital. From June 2019 to 2023. We had 29 cases in all, and here you can see, according to the textbook also, the papillary is commonest, and then comes the follicular, anaplastic, and then medullary carcinoma. Numbers are written here. So these are again the statistics. Now, as you know, papillary is more common in males, and females have more cases of papillary follicular cancer. This is age distribution. Here you can see the younger patients they come with papillary carcinoma, and the older age group anaplastic. This slide shows the number of mode of presentation. They all had neck lumps or swelling in the neck, all of these patients, and many of them had hoarseness or change in voice or stridor, which is related to the recurrent laryngeal nerve. Some had pressure symptoms, which you can also get with the other diseases. Yes, go there. Second, Auntie. Sorry for the interruption. So most of them presented, all of them really, with a breast lump in the neck and stridor, and some came with a lymph node, which was actually a carcinoma. Now, age we discussed, gender. Now, radiologist can also guide you when they do ultrasound. They will tell you whether it's malignant. There are classification, THY classification. And when you do an FNAC or take a biopsy, then also you can. Anyway, management, all these patients had surgery. 20 patients had total thyroidectomy and removal of the central lymph nodes, and 7 had. ये सारा कुछ गड़बड़ी हो रही. ठीक है. चलिए. Thank you. One had lobectomy, and this patient developed recurrence later on and had to be operated. And one case we had to postpone the procedure because of some anesthesia problems. So all cases, all surgeries carry complications, and post-op complications in our cases were 5 cases: hypocalcemia because of the injury to the parathyroids, and recurrent nerve injury, 2 cases, 1 hematoma, 1 residual thyroid, and we lost 2 cases. One was aggressive anaplastic tumor, and the other was she died of some unrelated causes. Now, luckily, all these complications, hypocalcemia, recurrent injury, and hematoma, they all resolved, and the result was good in these cases. Now, a brief overview of the topic. This is the thyroid gland. We all know it's a very vascular gland, and you can see lymph nodes here. These are the central or pretracheal lymph nodes which we have to remove, and you can also appreciate the close association of recurrent laryngeal nerves. While doing surgery, we have to take care of that. The whole of the gland in cancer cases has to be removed, leaving behind the 4 parathyroid glands. Now, this is incidence-wise the 4 out of 100,000 cases of population, you get these cancers, and more in the female. They present with a lump. And this is an interesting slide which shows the 30-year data that this incidence, both in males, females, it's increasing over the years. So the types we mentioned earlier also, common acids, papillary, then follicular, anaplastic, and medullary cancer, and then some other cases. There are different classifications, and I'll not go into that. Risk factors. Risk factors, the most important is radiation given to the upper part of the body. You remember the Chernobyl nuclear disaster which occurred in Ukraine several years ago, and the children born at that time or who were small, many of them developed cancer of the thyroid. Similarly, some genetics, and also long-standing ordinary benign multinodular goiter, then another form of goiter, family history, and multiple endocrine neoplasia. These are the risk factors. So briefly, I'll just tell you papillary cancer, 2 things to remember. One is it's multicentric. You have to remove the whole gland, and you can't do with the lobectomy. And the other thing is they metastasize into the lymph nodes. whereas this is what it looks like on FNAC. Clumps of cells, hyperchromatic, and the nuclear cytoplasm ratio is less. So this is, at a glance, you can see this is cancer. Now follicular, two things to remember more in the female, and they don't metastasize into the lymph nodes. They go directly to the bloodstream and up to the bone and other organs. This is what it looks like on histopath. Differences I've already mentioned. Now these patients will come to you with swelling in the neck, enlarged lymph nodes may be present, hoarseness of voice, and pain may be referred to the ears, and fixity. This is a fixed mass with the surrounding tissues. Or they may come with distant mets. So when you diagnose them, the important points here are extremes of age, sudden enlargement. When there is a sudden enlargement of any goiter, you should be suspicious. Compressive symptoms, any change of voice, you should investigate this patient for cancer of the thyroid as well, and discrete swellings, etc. They may come with bone pains or even fractures. On examination, similarly, you see all these findings, and one finding is Berry's sign, what we call, on the patient who has cancer of the thyroid. You do not feel the carotid pulse in these patients, so this is also an important sign. So you investigate by thyroid function test, antibodies, and thyroglobulin levels are done, and then biopsy, FNAC, and ultrasound is done, and then laryngoscopy, indirect laryngoscopy, to see whether the cords are moving or not. And in selected cases or recurrences, you do MRI. This is a case which radiologically it shows this is the trachea and multiple nodules. If you see a thyroid scan, isotope scan like this is a cold area, what we call, and this is a solitary cold area which is diagnostic of tumor, cancer. All these secondary tumors, they are given iodine, as you know, iodine, radioactive iodine, and you can see the secondaries wherever there are secondaries. Now this patient presented with the swelling of the forehead here. Yes. So sometimes they look very benign, and people think they are sebaceous cysts and even try to excise them. But if you see at this CT scan, the bone is eroded, and this is actually a tumor from the neck. So they may come to you with secondaries. Various prognostic factors, I leave the TNM classification, etc. Now, treatment options. Surgery is the main treatment in these cases. All these patients require surgery. And as I said, total thyroidectomy. Then radioactive iodine is given to the secondaries or residual tumor. All their life they will have TSH suppression by giving them thyroxine 4 tablets a day. And in selected cases, other things. Sometimes these secondary deposits in the neck, they can be removed also. Complications, I mentioned earlier, parathyroids can be damaged, recurrent nerve, and recurrence. Now, if you leave thyroid behind, like doing a lobectomy, then you may have to go in again. Serum thyroglobulin. This is done post-operatively every 6 months, and if there is a secondary deposit, then this is raised and you come to know. Thank you very much.
Jazakallah, Dr. Nasir Malik Sahib. Dear doctors, as we are running a bit short of time, the question answer session therefore will have to be skipped, and I would request the chairpersons for their remarks.
Assalamualaikum. Excellent presentations. I think there was a lot of very refined and updated information. Thank all the presenters. With regard to the red eye, as Professor Mansoor has very rightly pointed out, that it's a contagious disease and infectious disease. It spreads very rapidly into the communities. But if I'm not wrong, and if Professor Mansoor agrees with what I say, is that probably the last episode of red eye, which took place last year, was very short-lived. And I think the reason was that people had a lot of information with regard to the prevention of the disease, how to contain the spread of the disease. And although COVID-19 was a disaster or a pandemic and lots of people died, but it was a blessing in disguise in the sense that a lot of health education with regard to containing the disease, breaking the spread or blocking the transmission was available on so many medias. For example, the print media, the electronic media, and so many other resources were available. So people were aware of those preventive activities. And we have seen since morning, also besides the red eye presentation, I have been attending all the presentations today. Most of the presentations said that there was lack of information, which led to a very serious condition in the end. So I think one of the lessons is that we should, in the larger public health interest, we should, as clinicians, be always promoting the prevention and how to and educate the public with regard to prevention of the disease. That's very important, and I think clinicians can do it individually and on the public side as well. That's the only comment I have. Thank you.
Jazakallah, Dr. Abdul Bari Sahib. On behalf of Ahmadiyya Medical Association, I thank all the worthy speakers, respected chairpersons, and the audience for participating in this scientific session. And now request the presiding chairperson, Dr. Mirza Muhammad Daud Sahib, to kindly present shields to the speakers. First of all, Professor Dr. Atif Mansoor Ahmed Sahib from Lahore. Barakallahu lakum. Then Dr. Mubashir Mumtaz Sahib from USA. Barakallahu lakum. For presenting shield to Professor Dr. Zahida Rani Saiba, I would request Dr. Nasra Sabiha Daud Saiba to please. And now Professor Dr. M.A. Nasir Malik Sahib will receive shield from the presiding chairperson. Barakallahu lakum. One presenter of the last scientific session could not receive the shield because of shortage of time. I would request the president to kindly present shield to Professor Dr. Munawwar Ahmad Arai Sahib. Barakallahu lakum. With this, we conclude the fourth scientific session of the convention, and now is the time for general body meeting of Ahmadiyya Medical Association, Pakistan. Jazakumullah, Asl Jazak.